without wasting another minute, I think we should start with the class for today. And this is how many students are there tonight?
Right now there are 6, but many will join.
Yeah, okay. So we will have an interactive session. This is about infectious diseases, and infectious diseases is important from the examination point of view from two respects. One is that most of the infectious diseases, they would want to discuss it. Probably we have not seen in our clinical, rotations in India, because like they are more interested in them. Another thing is that their approach to infectious diseases is different from us. So they would want to investigate and they'll want to diagnose a condition based on the the physical findings and particular lab reports, like the specific investigations to arrive at that diagnosis. Uh, MRCP part 1 is mainly about arriving at the diagnosis, and part 2 is concerned with managing those problems with whatever guidelines are, whatever the tests, the recommendations that are in place, and how to follow them up. So as far as part 1 is concerned, we would like to understand about microbiology, about how they present, their posology, that means the symptoms and signs of the disease per se, and then how to investigate those patients, when to suspect what kind of an infection, and the next thing is pharmacology. So the antibiotics or the chemotherapy that is given, I mean, you must be aware that antibiotics are a kind of chemotherapy. So we have to understand that those questions based on therapeutics of infection will also be asked under the heading
Infectious Disease MRCP part 1, তাই তো?
Infectious disease, yes. All right, so we would like to have an interactive session. I would go with the question. I'll give you 5 seconds or maybe 7 to 10 seconds, not beyond that, to answer if you do get the question. In case you don't, I will move on to the answer slide. So this is a 16-year-old boy who is brought by his parents. So whenever you are looking at a question, you have to see, one, who is the subject in the question. If the subject in the question, his age, his ethnicity, his belonging of, the country to which he belongs, will give you a rough idea as to what they are going to ask in a question. Because in the exam, you will have 200 odd questions. So you will not know that this question is coming from infectious diseases. So immediately when they are giving you a person who's traveler, think of infectious disease. If they are giving you a history of joint pains after having traveled, diarrhea after having traveled, these are all infectious diseases. Young people, because they travel a lot, young people, they mingle a lot. So there are chances that the young people may come with some signs of infection and history of infection. So they are the subjects usually. So we have a 16-year-old boy who is brought by his parents to emergency department with a 5-day history of nausea, vomiting, headache, and lassitude. So 5-day history of nausea plus vomiting. So there is this along with headache. I reckon that this triple combination refers to meningitis. Something wrong with the brain, something increasing the pressure there, along with producing nausea and vomiting. On examination, he appeared to be confused. See, we were thinking about brain, meningitis, meningoencephalitis, and we have a confused patient. And was noted to have erythematous macule. So there will be, second will be symptoms will be given. Third will be an association will be given. This is how you approach these questions. Like you will have a subject, you will have basic disease which they want to ask. So they'll give you the symptoms of a condition. They will associate those symptoms with something. See, we have a 16-year-old guy who has headache, who has nausea, who has vomiting, who is confused, and all this is going on for 5 days. Association is erythematous macules. So these are all giveaway. and then they will give you something very special about the condition, so that you can arrive at a diagnosis in a quick succession. So they want you to make a diagnosis. They don't want you to trouble you, or they don't want to confuse you with options, but they want to help you arrive at a diagnosis. It is not that you cannot, it is just that you just have to correlate the data. That's all. So there are erythematous macules, especially on the lower extremities and trunk, but no macules were seen on the face. So there is facial sparing. His neck was stiff. So neck is stiff. So we are arriving at, there is neck stiffness also. These are signs. So they are signs. So sign is that the patient has neck stiffness. So everything of meningitis with a positive Kernick's. So neck rigidity is there, and there is positive Kernick. A lumbar puncture is performed and CSF comes out with high pressure. So there is increased CSF pressure as well. The CSF is turbid in appearance, and laboratory analysis of the same reveals an increased protein level 1 and neutrophilic leukocytosis 2. GSF show gram staining of the CSF shows gram-negative cocci. Which one of the following is most likely causative agent for this above condition?
Neisseria meningitis.
So how do you arrive at Neisseria meningitis? Have we identified the disease? Okay.
Yes, gram-negative cocci.
Okay. So what is the diagnosis here?
Meningitis.
Wonderful. So it is meningitis. Is it infective meningitis or non-infective meningitis?
Infective.
What kind of infection?
Neutrophilic leukocytes and
fungal?
turbid. Increased protein level and neutrophilic leukocytes.
So this is infective. What kind of infective? Viral, bacterial, or fungal, or protozoan?
Bacterial, most probably, because neutrophilic leukocytosis is there.
So there is leukocytic neutrophilia. And then another thing, they have shown you that there is a gram stain of bacteria is positive, gram-negative cocci. So this is meningitis. This is infective meningitis. In infective, it is a bacterial meningitis. And due to presence of gram-negative cocci, this is gram-negative meningitis due to Neisseria meningitis. If it was Streptococcus pneumoniae, what would be different in this question?
Not gram-negative.
Okay, it would have been gram-positive. What else? So how does this Streptococcus pneumoniae look like?
In chain.
In chain. Okay. So they can be flame-shaped also, no? Flame-shaped. So
Yes.
they are like in this kind of a chain. Okay. So these and Neisseria are classically diplococci. If it had to be a blood culture or a synovial culture, then you would find these diplococci in the WBCs. So Neisseria is notorious to be known to invade the WBCs and go there and sit inside the WBC. Okay.
Yes.
Now tell me which is an inherited condition in which there are higher chances of developing Neisseria infections.
Inherited condition. Can't remember now.
Okay. So all these capsulated organisms are attacked by the MAC complex C5 to C9. So whenever there is C5 to C9 deficiency,
okay,
there are higher chances of getting Neisseria infections. And what is an acquired condition in which Neisseria infections increase?
Great.
Splenectomy.
Yes. Forgot.
Okay. And which are the conditions in which splenectomy is done?
In case of this thalassemia major.
Okay. Sickle cell disease.
Sickle cell disease, yes.
Resistant or refractory ITP.
Yes, ITP also.
Okay, and hereditary spherocytosis.
Spherocytosis. Yes, all blood hemoglobinopathies.
Yes. So are we clear on this?
Yes.
Okay. So look for these situations, like they can say a 16-year-old boy, known case of sickle cell disease. So in sickle cell disease, there is something known as autosplenectomy.
Yes.
So even those candidates are more prone to develop Neisseria infections. Okay. Also Streptococcus pneumoniae, because it is also a capsulated organism. So we have to vaccinate against them.
Yes, vaccinate against two, Neisseria and also.
Yeah. So what is the treatment if I have to treat this patient? How will I treat?
Antibiotic. Ceftriaxone, zone.
Okay. So let us say somebody is sensitive to ceftriaxone, then
Cefixime.
fluoroquinolones. Okay. Just a second, hold on.
Fluoroquinolones.
निखिल मैं ना क्लास ले रहे हैं, कोई अर्जेंट नहीं? हाँ करा दो. आउटपुट है. एबीजी कैसी है? साथ नहीं चढ़ रहा. चलो फिर करवा दो डायलिसिस. ठीक है. All right, ठीक है. So this boy has meningococcal meningitis secondary to Neisseria meningitidis, and this form of, then we have all kind of situations here, but we have to see that Neisseria meningitis, it is gram negative coffee bean shaped, so it's a diplococci. This is how it persists. That may occur intracellularly. Now this is amazing quality, not every bacteria has it, or extracellularly in PMN nucleotides. So this is fastidious. Fastidious means difficult to culture. Okay. All right. So if you have to grow, you have to cook this bacteria in carbon dioxide agar. So it can grow in both in blood agar plate and a chocolate agar plate, because it needs blood. So chocolate agar and blood agar, they have this substrate in them which can help grow Neisseria meningitis. So colonies are gray and pigmented. You don't need to know that. So this is where you come. Streptococcus pneumoniae are gram-positive cocci in chain. This is differentiation. Staph aureus is usually looks like grapes. So they are like clusters. Haemophilus influenzae are gram-negative, but they are bacilli. Yeah, so they are bacilli. Pseudomonas aeruginosa, its name itself is very clear. Yeah, they are rod, but they can look like cocci also. They are pseudomonas. They don't have a fixed shape. They are pseudomonas. Pseudo means false shape. So whatever you see may not be correct. All right. So question number 2 for tonight. Okay, a 30-year-old lady. So she again is a young lady, referred by primary care physician for. She initially presented 9 days back with 4-day history of malaise, headache, muscle ache, and subsequently dry cough with fever. So what we have is something that started with myalgias, headache, and then culminated into dry cough and fever. Okay. The primary care physician started a course of antibiotics, which is amoxiclavulinic acid, but symptoms did not improve. So something which is not sensitive to this thing. On the day of referral, she still has cough and has become mildly tachypneic. She also complains of a global headache, myalgias, and arthralgias. On examination, she is appearing unwell, sick. She has fever of 102. She had an evidence of a maculopapular rash. So a 30-year-old female with all the symptoms of headache, then myalgias, dry cough, plus fever, with plus arthralgias. And also she has maculopapular rash. Could it be, okay, we'll come to that. Over her upper body, her heart sounds are normal. Blood pressure is 120/70. When you auscultate her chest, she has fine crackles audible on the left middle zone. So, left mid zone, the patient here somewhere has fine crackles. She also has mild neck rigidity. So can you think of some bacteria that causes sore throat, that causes systemic illness, causes pneumonia, that causes rash, and causes meningitis?
Sore throat, Streptococcus most common.
So let's go through the investigations. HB is 8.2 or 82 grams per liter. TLC is total count is almost normal, with reticulocytes increased to 7%. My God, hemolysis is happening somewhere. Which infection has hemolysis at the core of its pathogenesis? Mycoplasma?
Group B strep.
Okay. Group B, Streptococcus. Okay.
Streptococcus hemolyticus.
Okay. So hemolyticus is there. Fine. So there is hemolysis going on as evidenced by increased reticulocyte count, but you see total leukocyte count has not increased. So some bacterial infection or some infection which is not increasing the total count. Sodium is slightly low, 130. Which bacterial infection causes hyponatremia?
Legionella.
So Legionella occurs in elderly people, and there is a history of exposure to faulty air conditioning. So nothing of that sort has been mentioned, but we will keep it in mind. Okay. Hyponatremia also occurs in mycoplasma. The creatinine is 109, which is fairly okay. Urea is fine. Potassium is slightly on the higher side, 4.4. The bilirubin is 90.
Oh my God.
See, this patient has bilirubin. So hemolysis.
Hemolysis.
Serum alkaline phosphatase is only mildly elevated, and AST is also mildly elevated. We are not concerned much. GGT is okay.
Then
All
Legionella.
right. So we have this picture. So chest radiography shows patchy consolidation in both middle zones. Which of the following is most likely cause of her abnormal blood count? Okay. We have sepsis syndrome. We have IgM anti-I antibodies. IgG directed against Plasmodium antigen complex, clavulanic acid, 𝑨𝒃𝒑 deficiency. Nice question.
Maybe 𝑨𝒃𝒑.
Amoxicillin clavulanate is not, kind of mentioned as one of the reasons. So patient has anemia, 8.2 grams, and the patient has all these features. So hemolytic anemia due to any infection. Oh, this patient has mycoplasma pneumonia infection. So as I had mentioned, this all is hinting towards mycoplasma. Can you see? We had already mentioned here. So mycoplasma pneumonia produces IgM antibodies, which are cold agglutinins. So these IgM antibodies, they bind to the RBCs, clamp them up, and get their hemolysis done, leading to jaundice and anemia. So this patient has IgM antibodies. Okay, this is cold agglutinin. All right. So now let me brief you on cold agglutinin disease. I mean, autoimmune hemolytic anemia is very important from MRCP point of view. You must read. And in autoimmune hemolytic anemia, you have two kinds of antibodies. One is small antibody, which is IgG. The other is large antibody, which is IgM. So IgG causes hemolysis within the blood vessels, and IgM causes hemolysis in the spleen.